Welcome to Emergency Medicine Lecture Series, Brief Lessons in Trauma. Today we're going to discuss basic trauma management. So first, what to expect. So you get a call from the nurse, there's a pre-hospital notification. The notification is there's a patient that's been ejected from the car and you hear that the vitals are unstable. Heart rate is 120, blood pressure is 80 over pelvic. So what does that mean? She calls a level 1 notification. There are different levels in the trauma activation criteria. Level 1 is the patient is expected to likely go to the OR immediately. So you have the head of the trauma service, you have the senior orthopedic residents, you have anesthesia called just to expect any potential life-threatening injuries, and everybody is working in concert with the emergency medicine team. Level 2 is patient is unlikely to get to surgery, but they may go to surgery. And level 3 is patient is definitely unlikely going to surgery unless we find if there's any other significant injuries immediately. So patient comes, where do people stand and what do they do? So the person on the right is usually the nurse. She's placing on the blood pressure cuff, placing the patient on a monitor, placing oxygen on them. And on the left side you have junior resident placing an IV, or they'll be doing any procedures such as placing a chest tube or central line. Person at the head of the bed is always in charge of the airway. So they will, if the patient is unable to have a patent airway, establish one immediately. And the person at the foot of the bed is the one who's leading the trauma. And this is usually the chief resident. This person is making sure everybody is going over their roles and doing everything precisely and in an orderly fashion. So, as a med student, where do you stand? So you want to be involved, but don't get too close to the patient or in the way of the other residents unless you're asked to come in and help. Once you're asked to come in and help placing a line, help getting the patient exposed, then everything's a go. So next, we have the patient on a monitor, we have IV access, preferably 18 or 16 gauge. Now you go through your CABCs. First C stands for catastrophic bleeding. If there's like a large scalp gaping wound that's profusely bleeding, you want to stop the bleeding immediately. Next, you want to go through the airway. Airway, you're looking in the mouth to see if there's any blood, checking the trachea, pressing to see if there's any crepitus. If the patient responds in a normal voice, and then the airway is patent, and you go on to the next step, which is B. B stands for breathing. So you're looking to see if the patient has equal chest rise, if their breath sounds are equal, checking to see the rate, if they're tachypnic, and also making sure that the O2 set is appropriate. Second C is circulation. During circulation, you're assessing for shock. So making sure that checking the blood pressure, making sure there's palpable pulses in all the distal extremities, and making sure that we have good IV access, preferably 2 large bore lines, again, on the left and the right. D is disability. Disability, checking for level of consciousness. And E is exposure. You want to get the patient completely undressed to monitor for any injuries whatsoever. So next you have the adjuncts to the primary survey, and that begins with the FAST exam. The FAST exam is going to go over several points: the right upper quadrant, left upper quadrant, the cardiac area, and the bladder. And you're looking for any evidence of blood because that will essentially make sure that the patient will need to go to the OR sooner than later. So on the right upper quadrant, you're looking at Marsden's pouch between the liver and the kidney. You're also looking between the diaphragm and the liver and the inferior pole of the kidney to check to see if there's any evidence of fluid. Then you go to the left upper quadrant, and that is the splenorenal recess. Again, between the kidney and the spleen. Next, you're looking at the cardiac area for the pericardial effusion or any tamponade. So you have 2 places you can look for: the subxiphoid process and also the peristernal lung process. After that, you go to the bladder and you're looking again to see if there's any fluid around. So after we do our primary survey and the adjuncts, which also may include a chest x-ray, a pelvis x-ray, depending on the mechanism or if there's any injuries, you move on to your secondary survey, where you do a head-to-toe full exam, checking for any other injuries. Don't forget, you always want to check a quick brief history. It's called the ample history. Checking for allergies, medications, patient's past medical histories, when was their last meal, and what was the environment they were in. This can give you a lot of pertinent information going forward. So, briefly, we're going to go over summary points, and remember to go over the primary survey. ABCDE approach: airway, breathing, circulation, disability, and exposure. These are universal principles for all patients, and it's applied when critical illness or injury is suspected or evident. Assess and we treat continuously and simultaneously. Everybody's doing their job at the same time. We always treat life-threatening signs immediately, and this is life-saving treatment does not require a definite diagnosis. Always reassess regularly at any sign of deterioration. This has been the basic lessons in trauma management.